connais bien parce qu'elle est associée éditeur du journal que je suis rédacteur en chef depuis 8 ans. Elle est aussi, pour ceux qui connaissent la Cochrane Library, c'est elle qui est l'associée éditeur pour les maladies infectieuses, c'est l'analyse systématique de la littérature, les méta-analyses. Elle est infectiologue et elle est particulièrement investie dans un point qui est devenu important, c'est est-ce que les antibiotiques, ça doit être géré comme chacun veut, ou est-ce qu'il faut diriger l'organisation du traitement par des gens qui connaissent les antibiotiques. C'est une vraie question, c'est un sujet très très actuel qui montre qu'en général il y a une différence très significative dans la mortalité, pas dans les détails, la mortalité si les gens utilisent d'une manière rigoureuse les antibiotiques à côté du fait que les gens les utilisent comme ils viennent. C'est un vrai problème pour tous les gens qui travaillent dans les maladies infectieuses. Les gens qui travaillent en hématologie, par exemple, il n'y a pas de variation d'un opérateur ou d'un jour sur l'autre pour le traitement qu'on donne. Mais en maladie infectieuse, c'est des parents, quand vous allez dans la réanimation, chaque jour, celui qui est de garde change le traitement antibiotique. Donc il y a une labilité dans les antibiotiques qui est tout à fait inouïe et qui va avec une mortalité importante. Donc c'est ce changement-là qu'il est important de faire et c'est vraiment un des leaders mondiaux de l'évaluation des recommandations et de la mise en place du traitement antibiotique dans les maladies infectieuses. Mihal, very happy to welcome you.
Okay, thank you very much for the kind words and thank you for the invitation. I'm much honored to speak in the leading place for microbiology in the world. I'm a clinician and I hope that my talk won't bore you too much because I think I'll be speaking of things that you see less. I'll start by describing where I come from so that you understand a bit where I'm coming from, where we live. Yesterday I had a wonderful day here in sunny Marseille, but Wednesday was just a normal day in the hospital, and I'm presenting just 2 patients of the many patients that I saw on that day. The first one is a 30 years old boy, man, for us it's a boy because we see elderly patients. He was in a motor vehicle accident, he had traumatic brain injury. He needed some surgery, he needed a lot of surgery, neurosurgical operations to drain, to fix, to monitor the pressure in the brain. He was discharged to rehabilitation following a very prolonged hospitalization, about 3 months in the hospital, intubated, many infections, you can guess, many courses of antibiotics, ventilator-associated pneumonia, etc., etc., etc. He was in rehabilitation for about 2 weeks and he reached the level of consciousness. He was opening his eyes. According to his family, he was contacting his family. He could read and write, which is phenomenal after the type of injury that he had. He could not speak, he what we call aphasic, and but he could communicate with his family through writing and through his eyes. He was readmitted due to fever and the fact that he declined cognitively, meaning he could no longer communicate with his mother. And this is what we found on the CSF culture. This is an Acinetobacter that is multi-drug resistant, or XDR, extremely drug resistant. It's susceptible only to, as you see here, to amikacin, to colistin, and to tigecycline. We have a problem with these last resort antibiotics. These are old antibiotics that we've more or less discontinued using because we have more effective antibiotics. We have antibiotics with better pharmacokinetic profiles, with better efficacy profiles, with better safety profiles. We've stopped using these antibiotics, but nowadays we've gone back to needing them, and they're less effective than the antibiotics that we have. They do not penetrate the brain specifically. The drugs that we see here have tigecycline is susceptible according to all the CLSI criteria. This MIC would have been considered already resistant by the European criteria, so it's not really a consideration to treat meningitis as a peristaltic drug and poorly effective drug. The other drugs simply do not penetrate treatment and drainage, mainly mechanical treatment for an infection to which we do not have antibiotic treatment. Intrathecal antibiotic administration, meaning we administrate antibiotics directly to the CNS because they do not reach the CNS from the systemic administration. He was discharged back to rehabilitation, but very quickly was readmitted to the hospital. And you see here a fever curve from September to the day I left the hospital, the 4th of November. He is febrile. He is extremely febrile. He's no longer recognizing his family. He can open his eyes and that's it. We've done an extensive evaluation of his fever and the source of his fever. We have nothing. He probably does not have a CNS infection now. All that he has is a persistent pneumonia with this pathogen, another gram-negative pathogen that is resistant to everything except for colistin, a drug that does not penetrate the lungs well. I saw the patient yesterday. We had a discussion in the ward. What are we doing after 2 months of fever and endless antibiotic treatment? We said we stop antibiotics, we give physiotherapy, we give just paracetamol to reduce the fever, and we help his mother cope with this terrible accident, I can say, of life in the hospital. The second patient was a 67-year-old woman with lymphoma, CNS involvement, multiple recurrences of the lymphoma. She was admitted for bone marrow transplantation, autologous bone marrow transplantation, and she was transferred from us from another hospital in Israel. And on admission, she was colonized. We knew that she was colonized by rectal surveillance cultures with a carbapenem-resistant Klebsiella isolate that is endemic to Israeli hospitals, and we have a national system of reporting cases of colonization so that everyone is aware of all patients. Quite as expected, after 7 days when we infuse the step, we first give intensive chemotherapy, we eradicate, we cause severe pancytopenia, meaning we try to destroy the endogenous bone marrow, and then we transfuse the patient's bone marrow back, but until the white blood cells recovers, the patient is extremely immune suppressed, and we know from previous experience that the patient will do a bacteremia with this pathogen that is colonizing his gut. And this is what we had in the blood, and again resistant to everything. In this case, the e-tests for colistin were finished in the hospital, and we couldn't examine colistin, but we knew from local epidemiology that it should be susceptible to colistin, but practically to nothing else. She recovered from the bacteremia. The isolates in our hospital are carbapenem resistant through KPC in 90% of the cases. Some of them are NDM, OXA48, but our CREs are KPC positive. And we don't have here MICs, but they are highly resistant to these antibiotics. You see the MICs for the carbapenems. It's hardly a consideration to give them carbapenem therapy for this isolate. Now she's about 3 weeks after the infusion of the stem cells, and she's no longer neutropenic. She does have leukocytes, but she's persistently febrile. She continued with fever all these 3 weeks, and after she's regenerated her bone marrow. And now she has this carbapenem-resistant isolate in her bronchoalveolar lavage. And she has pneumonia caused by this pathogen, again, very resistant to any therapy that we're trying to give her. We showed this in big numbers using the cohort study design. We looked at all the gram-negative bacteremias in patients in our hematology unit, and we tried to analyze the costs of having the carbapenem-resistant bacteremia. What does the patient pay for the fact that he had such an extremely drug-resistant bacterium in the blood? And this is a multivariable analysis of other risk factors for mortality. This is 14-day mortality, the outcome here. And we see the expected risk factors for mortality, the patient's functional status, septic shock, the previous comorbidities, the type of chemotherapy that he's received, and we see the adjusted odds ratio for having a carbapenem-resistant gram-negative bacterium 5 times the odds of death within 40 days as best as we can adjust. And the 2 examples I showed you demonstrate how bad this study is. You can never adjust for the fact that it's the sick patients who have these bacteria. The sickest patient, the one with the recurrent lymphoma, the one after 3 months in the hospital, these are the types of patients that have carbapenem-resistant gram-negative bacteria, and no matter what type of statistical analysis I will use, I will not be able to adjust for the differences between the patients having resistant and susceptible bacteria. But as best as we can understand, this is the cost for the individual patient. And this persists on the long term. Continued follow-up for up to 1 year, and the curves separate early and continue separating, meaning it has a real impact on the survival of the cancer patient or the patient with a leukemia usually. Why, I'm asking myself, why is it that in Israel it's like that? Why here not? Where does the difference come from? Is it some antibiotic use, general antibiotic use in the community, and our patients come more practiced with antibiotics, more colonized with selection of resistant bacteria to the hospital, and then they receive antibiotics and become highly resistant? I don't know whether it's antibiotics in animal feeds in Israel or in other countries like ours, like Greece, like some parts of Italy, and some parts in the US. Is it only the antibiotic pressure in the hospital? Are we behaving differently with regard to antibiotic use in the hospital? Or is it in hospital infection control? Is it something that everyone acquires resistant bacteria, or every antibiotic selects for resistant bacteria in the gut, but poor infection control can spread these resistant bacteria between patients? So what exactly are we doing bad? I'm not sure. But I'm pretty sure that the antibiotic pressure in the hospital has an effect, is somewhere contributory. Look at the antibiotic consumption in Israel. It's presented as DDD, which is the daily dose of the typical daily dose of antibiotic given per 1,000 insured patients per day, 100 population, let's say. It's around 20-25. And look at the antibiotic consumption in Israeli hospitals. It's different in the ICUs, like Professor Raoul said, where antibiotics are continuously being given to the patients. 150 or 160 DDDs per 100 patient days means that each patient receives more than 1 antibiotic per day on average, 1.5 on average. In medical wards, it's a bit more than 1 per patient. Of course, it's not each and every patient receiving antibiotics, but one patient receiving 2 and the other not receiving. That's the calculation of the DDDs. But you see the immense difference in the antibiotic pressure in the hospital compared to the community. Here it's per 100 patients, and magnitude bigger than the community, where it's per 1,000 inhabitants. We recently compared ourselves to what's happening in the world, just to understand if Israel is very different than other parts of the world. And what you see here on the graph is on the x-axis, we have the DDD per 100 patient days in acute care hospitals published in the literature. And on the year axis, we see the year of the publication of the study, or the year of the study. And you see that there's a wide variability between hospitals and consumption rates, and it doesn't change with time. Always and ever there's been a huge difference, and ours is the red spot. We're relatively on the top of what is normal, considered normal consumption, or the normally reported consumption. I'm not sure where you are. Do you have an idea?
I don't know.
I would guess, just by looking around how similar the streets are, I would guess that it should be the same, but I don't know. So why is antibiotic consumption consumption so high in the hospital? I have my explanation to this starts very, very long ago. This was the first use of antibiotics and the first study of antibiotics, the effect of antibiotic therapy on pneumococcal bacteremia. The untreated patients in the era before antibiotics, then serum, and then penicillin treatment. And you see the huge immense effect of antibiotics. It's really, for me, it's a wonder drug. It's a really miracle to have penicillin. And then, like this study, there have been many studies, and this is a summary. You see here a meta-analysis funnel plot summarizing studies, comparing not with and without antibiotics, because nowadays we give antibiotics to patients, but patients that received initial covering therapy versus patients that received inappropriate or initial non-covering therapy in the first 24 to 48 hours of infection. And what this graph shows you is that almost all studies show an advantage to appropriate therapy. This is the line of equivalence, the line of 1. And all studies to the right of the graph here show a benefit to covering antibiotics in the first 24 to 48 hours. And the pooled summary estimate is an adjusted, and these are adjusted results for multivariable analysis, and the pooled result is about odds ratio of 2, meaning twice the odds of survival, of living about 30 days after the bacteremia if you receive covering antibiotics within the first 24 to 48 hours. And this is a huge driver for clinicians. Clinicians have learned that. They know these data. And these data are published in the surviving sepsis campaigns and a lot of campaigns coming from ICU people that promote fast and aggressive antibiotic use to save lives. But what's the problem behind this evidence? And I say a bit of mea culpa. I shouldn't have published this. This is confusing, and I think it leads to the type of antibiotic consumption that I showed you. I'm kind of sorry for this. And now we're doing the reverse meta-analysis. The next one will publish the opposite results. Because the main problem with these studies, obviously they're not randomized. No one is going to randomize people to receive bad or good treatment. But the problem is that these studies start with a cohort of patients who have an infection. By definition, to analyze the appropriateness of therapy, you need to have an isolate. You need the patient to have an isolate. And nearly all these studies focused on bacteremia, not just an isolate, on patients with severe infections. So obviously they show a benefit. But the patient that comes to the emergency room, the one that has fever on day 7 in the ward, we don't know if he has a bacteremia. Most likely he doesn't have a bacteremia. Bacteremia is a rare event. Most of these patients who don't have a bacterial infection at all, but all of them receive antibiotics. All of them receive antibiotics because this is what we're taught, that antibiotics prevent death when there is a bacterial infection. So this is the problem with the way we're presented with evidence, and to my opinion, this leads to the antibiotic consumption in the hospital that we see. Antibiotics, I compare antibiotics to the concept of tragedy of the commons. Each person acts in self-interest, or each physician acts in the best interest of the patient in front of him. But he's overlooking the fact that overuse of resource may end or destroy it. We're not looking at the picture, at the future. We're looking at the patient in front of us, and we're not thinking much about the future. And if I summarize my appreciation of this wonder treatment, antibiotic treatment, I'm pretty sure that there is no intervention in medicine as effective and that saved so many lives like antibiotics. But there's also no other instance where treatment of an individual affects the other patient, where we get cross-transmission of isolates from one patient to another, and there is no treatment that consumes itself. There's no treatment that we give, and the day after we get in the gut bacteria that are resistant to these antibiotics, and I think that by definition we do. Maybe not most of the bacteria in the gut, but some of the bacteria immediately become resistant to this antibiotic because they have long background to the antibiotic stewardship program. I had the benefit of moving from one hospital to another about 3 years ago. And the hospital that I met when I arrived to this hospital was kind of an island where there was no antibiotic stewardship ever. No one ever tried to promote any concept that antibiotic use may harm the patient eventually, that antibiotic use is leading the hospital to be it was the top hospital in Israel with regard to the prevalence and incidence of carbapenem-resistant infections. And I find it as a privilege because you can only improve from the state where the hospital was when I came to it. So the first thing that I had to do was to introduce the concept of what I call ecological costs, what I call the price of administering an antibiotic. And I had to present it to physicians and to nurses and to senior physicians and to young junior physicians, those that take care of the patient during the evening, during the night, those that are really prescribing the antibiotics and those that give the antibiotics and those that tell the physicians what to do. So the concept of cross-transmission, the fact that we have a few patients isolates and then we have the whole community isolates. This is exactly what we see in the ICU. We see one Acinetobacter in the sputum of a patient and the next day the whole ICU is colonized with this Acinetobacter. I showed physicians the correlation in the hospital with years between the carbapenem consumption and the prevalence of carbapenem-resistant bacteria. And it's not a trivial association because you don't treat carbapenem-resistant bacteria with carbapenems. So it's a really consumption-resistant pattern. I showed the nurses and the physician the concept of resistant selection. I showed them studies showing that you give an antibiotic and you get a patient colonized by bacteria resistant to this antibiotics. I saw here a completely different concept of culturomics. I'll show you another culturomics effect, and that's the antibiotic consumption in different regions of the world. And I'm pretty sure that the culture, the societal concepts of disease and the end of life and aggressiveness at the end of life have an impact on the amount of antibiotics consumption, and we see that on graphs here showing in Europe the prevalence of antibiotic use in the community, how different it is. To the infectious disease clinicians in the hospital, I also had to introduce the concept, and I told them that the physician obviously, and that's his role, he prescribes antibiotics for the present patient. He has to treat the patient in front of him. And we as antibiotic stewardship people have to take responsibility for all patients, those in front of us, but also for the patients near this patient, his neighbors, or patients in the future, or a year ago, or 10 years from now. Somehow we have to weigh in the same model the benefit to the present patient and the harm to the future patients that we're not seeing in front of us. So what did we do? Well, what was our antibiotic stewardship campaign? How did we try to improve the antibiotic use in the hospital? We started by formulating hospital guidelines. We need guidelines for the common indications for pneumonia, for UTI. What do you give in my hospital in Rambam? We have to select one preferred antibiotic, not a list of antibiotics like we have in international guidelines. We address the local epidemiology, what we have in the hospital, some ecological preferences that are our own preferences and understanding, and then we needed to distribute and implement these guidelines. I must confess that we're at the stage of implementation, not so much of checking how compliant the physicians are with our guidelines. We're just distributing them for now. My hospital has a complete electronic patient file, and everything happens electronically. Before I came to the hospital, the physicians would open not a request for consultation, but a request for antibiotic approval, because antibiotics had to be approved for continued use. The physicians would start the antibiotics, and the infectious disease clinician would need to click on the patient for the antibiotic to continue after 48 hours. And I hated this approval process, and the first thing I did is to completely abolish it and to change approvals to medicine, to change approvals to consultations. Each and every request for antibiotic comes with a consultation. We see the patient, we discuss the patient with his clinician, why and the diagnosis and the diagnostics that we'll use, and what bacteriology is relevant and what we recommend. I go monthly to medical wards and I sit with the physicians and we discuss antibiotic selections. We go through all patients hospitalized and we discuss why they're receiving their antibiotics. We discuss the infection, the diagnostics that were performed to diagnose the infection, if they were optimal, and the choice of the antibiotic treatment. With surgeons, this doesn't work. You cannot sit with a surgeon and try to discuss with him his antibiotic choices. So we enter the surgical world through other projects like surveillance of surgical site infections. They like that. They like to see numbers. So this is very time-consuming work, but we go and we monitor each and every patient operated on. This is our cardiac surgery department, for example, and we show them numbers and numbers. We show them numbers for the global outcomes of their operations, and we show them also surgical site infections. And then through this window, we can open a window to discussing the antibiotic treatment, the impact of their antibiotic choices, and the fact that a third of electively operated patients undergoing coronary artery bypass surgery receive antibiotics post-op, which is unreasonable. This gives us a window of opportunity to discuss this issue with them. We have to obviously standardize prophylaxis. It's a huge opportunity for antibiotic prescription in the hospital, because it's something that is routinely given to a whole bunch of people, like people who are operated on receive antibiotic prophylaxis. And if you don't standardize the type of prophylaxis, the duration of prophylaxis, the fact that prophylaxis is not effective after the operation, this is a huge source for antibiotic consumption. And I changed the antibiotic, despite my hate of the antibiotic approval process, I still think that antibiotics are so unique, they're such a miracle that we have to conserve, that I did mandate antibiotic approval, and there is an approval required to start, but not to continue, but to start antibiotics that are conceived as ecologically expensive or last resort drugs, like this colistin that you saw, the tigecycline that you saw, or carbapenems for that matter, are restricted. This means a whole reorganization of the hospital. We need 24/7 ID on calls to be able to approve antibiotics during the night, weekends, etc. And a lot of psychotherapy, because mostly the senior physicians and the heads of the department conceive this as a lack of freedom, that I'm taking some freedom from them, and it's their job to give their patients antibiotics, and who am I to tell them to give or not to give an antibiotic to the patient? It needed a lot of patient discussions with these heads of the department to introduce the concept and to explain why this is needed, why this is not going to hurt the patient, this is going to improve, eventually, this is going to improve the outcome of the patient. And what did we achieve with all that? We achieved a reduction in antibiotic use. You see 2012, the start of the antibiotic stewardship program, and November 2015. Again, DDD per 100 patient day use of antibiotics. We achieved a total hospital-wide carbapenem use reduction, and this graph is a bit confusing. I think there was a large consumption, and if I go back before 2012, the consumption was around 5-6 DDs per 100 patient days, which is immense. It's 6% of patients receiving carbapenems each day, and it went to an average of about 3. It reduced immediately when we introduced the empirical antibiotic authorization process. But overall, when I look at total antibiotic use in the hospital, I think that nothing happened. We were 95 and we stayed 95. It's fluctuating, but it's not fluctuating in any trend that I like. And this has been described before, the squeezing the balloon concept. I work intensively with medical wards. I increased antibiotic consumption in the medical wards, but it's going up. Sorry, it's going up somewhere else where I didn't intervene. I'm restricting the use of carbapenems, and I get use of cephalosporins or other antibiotics or colistin. I'm squeezing the balloon. I'm not doing something very effective. And I must confess that I think that standard antibiotic stewardship programs have failed to curb the resistance epidemic worldwide. I think that forever and ever we've been speaking about resistant bacteria in our patient, the fact that we don't have antibiotics, the fact that, and we're doing antibiotic stewardship all this time. This was a very rare hospital that I arrived to with no antibiotic stewardship program. In Europe and the US, these programs are very advanced, and they've been so for the last, I think, 20 years for sure, and we don't see a curve in resistance occurring. We don't see wonders from these programs. So what do we do? How do we fight this problem in the hospital? I'm bringing two solutions. The first is the perfect diagnostic. The problem is that we're working in the gray, we're working in the dark. If we knew exactly from the onset if the patient has an infection or not, we'd know whether to give an antibiotic or not, and preferably we'd know what to give the patient. We'd give the least broad spectrum antibiotic that we can choose so as not to promote resistance. There's no doubt about that. There's also no question mark about this. Each and every clinician will agree with me that if he knew what the patient had, he'd treat him. No use to over-treat the patients. So I list only 3 things that I need for my perfect diagnostic. I need it to be at the point of care. I need it to rule in and rule out the bacterial infection. It's very nice to have PCRs of metapneumovirus or influenza or viruses, but the fact that there is a virus does not rule out a bacterial infection. And in fact, the patients diagnosed with viral infections, upper respiratory viral infections in my hospital, get the same amount of antibiotics as the patients that do not have a viral diagnosis. So what I simply need is to know if my patient has an infection that needs antibiotics. And then I need the antibiotic susceptibility panel for this infection. I don't need the name. MALDI is very nice. It's nice to know that the patient has a Klebsiella in blood. But what will it help me? My Klebsiellas in my hospital are either pan-susceptible or ESBL or carbapenem resistant. I can tell a bit by the time of in hospital how likely they are to be carbapenem resistant. But to tell you the truth, I have no idea and no way to predict ESBLs, because we have these ESBLs coming from the community. So no idea what antibiotic to give. This is for me the perfect diagnostic, and I don't think we're there. I'm afraid that we do not have the perfect diagnostic yet to change antibiotic consumption in hospitals in an effective manner. I'll be happy to hear if you can contest that. And my second solution is decision support systems. I bring here a few numbers to show you how complex the decision of prescribing antibiotics is. In fact, it's the simplest decision in the world for the physician. Like Professor Raoul said in the introduction, hematologists have protocols. They treat this and that. The clinician in the emergency room sees a patient with pneumonia and gives that just like this. He decides what to give to the patient. He doesn't spend a minute thinking about it. But if we break it down to what it takes to adequately prescribe antibiotics, we reach a huge matrix of data that is needed if we were to think of probabilities. The probability of a bacterial infection, of a specific diagnosis, of the pathogen per diagnosis, of the resistance patterns of my pathogen in my patients with my risk factors, etc., etc. Decision support systems can handle such a matrix. Computers nowadays can take, and most of these data are available. Take an electronic patient file, take a microbiology database, and you can predict most of the numbers in this matrix. And the computer can do the matrix, and the computer can do the calculation very, very quickly. I'll rapidly describe a computerized decision support system that we've developed. We've developed it in collaboration with the partners. It was a new project already a very long time ago. It was a collaboration between medical informatics and clinical clinicians, us. It's a system we modeled using causal probabilistic network, and I'll show you in a second what that is. The purpose of the system is to diagnose the probability of infection to start with, and then to diagnose the severity and the probabilities of different pathogens causing the infection. And this is done using individual patient data that are entered for the specific patient, demographics, the background conditions, the physical examination, the labs that are available initially when a physician prescribes antibiotics. And then it prescribes antibiotics based on a cost-benefit model that I'll show you again in very brief. What is our time?
Well, we got 10 more minutes.
Okay. A causal probabilistic network models the variables we think that belong in the model as probabilities and connects them using causal pathways, using pathogenesis as we understand it. So it's a very easy model for a clinician to develop, because we understand the biology of infection, and what we need is numbers to populate, numbers for probabilities. The cost-benefit model takes into account the fact that antibiotics save life, they also reduce hospital stay, and they cost the drug, the price of the drug, which is very minor. They cost some adverse events to the patient, like Clostridium difficile, but mainly they cost the future. They cost the future of the patient, the individual treatment, because he will be colonized with resistant bacteria. His next infection will be difficult to treat, and there are future patients that will suffer because of this treatment that I'm giving to my patient. I think I'll skip the ecological cost part. It's a model that was developed within the project. It was published. And we tested the system in a randomized controlled trial where we randomized departments. Some departments used the system, some departments did not. They were using local guidelines, and we showed that the rate of appropriate empirical treatment, meaning covering antibiotics within the first 48 hours for those patients with microbiologically documented infections, improved in the wards using the system. This was our primary outcome, and when physicians adhered to treat, because they didn't have to adhere to treat, and when they adhered to treat, the odds ratio was much bigger. They were 3.5 times more likely to prescribe the appropriate empirical antibiotics. We're not powered in the randomized controlled trial to show an effect on survival, but we did follow up these patients in the control and in the ward to see that we're not harming the patients. And the blue line is the intervention wards, and there's a benefit to the intervention with regard to long-term survival. It is not statistically significant, but it's something that we think might be real. And this is the way it looks. This is the kind of data that the system uses. Very simple data that are known to every clinician, and it tries to to obtain the data as much as possible from the electronic patient file, so that the physician doesn't have to enter manually, especially numbers. All numbers are taken from the labs automatically. And then the system provides a diagnosis, provides an expected pathogen distribution, depending on the place of acquisition of the infection. Was it from the community? Was it from the nursing home? Was the patient weak in the hospital? We have the pathogen distribution in the system, and we have a recommended treatment based on our cost-benefit model. So for this pyelonephritis in the hospital, the top-ranked pathogen is E. coli, and the top-ranked choice of the system was amikacin. The physician actually prescribes ceftriaxone. For pneumonia, strep pneumonia, top choice penicillin. We promote penicillin for community-acquired pneumonia caused by strep pneumonia, and this is what the system recommends. For hospital-acquired pneumonia, the pathogen distribution is local. This is our pathogen distribution for pneumonia, and the system's top choice is piperacillin tazobactam, and the physician has to either approve the system's recommendation or to write. He can write also another treatment, but then he has to explain why he is not following the system's recommendation. What are the differences between this and the standard antibiotic stewardship program? This system will focus on the run-of-the-mill patient, not on the interesting cases. We, as antibiotic stewardship and as IBD clinicians, we go and find the Q fever, the Bartonella, the carbapenem-resistant infections, the brucellosis in Israel. We focus on the very interesting cases. This is going to run on each and every patient that receives antibiotic treatment. It's pretty boring. It uses, we've modeled a huge system. We've put, I don't know how many thousands of numbers into the system, and finally it prescribes about 5-7 antibiotics overall. It does a very boring job. It prescribes aminoglycosides for all UTIs, penicillin for community-acquired pneumonia, piptazole for hospital-acquired pneumonia, and that's just about it for most of the patients. As I said, it's going to guard each and every antibiotic prescription because we're not going to allow prescription of antibiotics in the electronic patient chart unless the physician went through treat and either accepted the recommendation or stated why he's deviating from the recommendation. It's educational. We're also educational, but this is a bit more educational because it's boring. We like to be artistic in our consultations. We like to give new antibiotics. We like to be interesting. The system doesn't know how to be interesting. It can be updated more easily than physicians. A year changes, we change the calibration file for the susceptibilities, and the system prescribes relevant antibiotics for the year 2015. And it's even more annoying to clinicians than me. I'm pretty annoying. This is even more annoying. And the efficacy of this, I don't know. We're now installing the system for use. I think in a month or two it will be operative in the medical wards, and then we'll see the acceptability, how annoying this is, if I lose my job or if we incur the resistance. So, if to conclude, I'm pretty sure that antibiotic pressure in the hospital care is only as consequences to the patients. I think we're doing them good, but we're doing them as much harm as good, I think. So I think at least as many patients suffer from futile antibiotic use than those that are saved by antibiotics for severe infections. Rapid diagnostics are needed, but even if we have this perfect diagnostic test, it will never replace, I think, the need for antibiotic stewardship because there is colonization, because some infections will never be microbiologically documented because, as you know, there are some bacteria that we haven't identified yet. So we need antibiotic stewardship in the hospitals, but the optimal strategy, I think, is yet to be discovered. So thank you very much.
Well, I had two or three questions and comments. First, do you have minocycline in Israel?
Yes, it covers the
So the two first cases, you should treat them with minocycline and cure them.
Okay, I give that as a
We've tested that.
high expert opinion.
So we've tested that with Greg, you know, nearly all the Acinetobacter and all the Klebsiella are susceptible to minocycline, but everybody forgets.
IV minocycline or?
Yeah, well, you can use IV minocycline. There is IV minocycline, but you need to order it or to keep that in your country. So this is one of the main reason why I'm going to say is that, and I think that there is a shift that people did not realize is that we were looking, and this is the pro and con story that we're going to do together, is that people are waiting from innovation and pharmaceutical industry to get new compounds, and I think it's a mistake. I think now we're in a moment where we got a patrimonial of many antibiotics, and we need to use all of this, despite the fact that nobody is making money out of it. And this is a problem. So you need to use fosfomycin and minocycline and so on, and to be to play with all this, because of course, I mean, antibiotics play a role. So it's not unique, but they play a role in the resistance. And of course, you need to get a balance between the ones that you use and the resistance that appear. Now we get plenty of bug resistant to colimycin, even naturally resistant. Just you do not select resistant, but you select the bug for resistant. So I think this is part of the problem, and the part of the problem is that we have not been managing that as a patrimonial capital, but like, you know, with the pharmaceutical industry we did. The reason, I suspect that one of the reasons here in Marseille, antibiotic stewardship on the hospital is impossible. People will turn mad, will kill you, or they want to do whatever they want. So we get a war about doing this. But the way we have been fighting this is, to tell the truth, is fighting the pharmaceutical industry. So 20 years ago, we get a terrible situation in resistance because 2 or 3 of the critical care units were already paid by the industry. So at each time when a new compound arrives, and of course the number of prescription, it's not only the quality, but the number of prescription is based on it, because they were paid by inclusion. So they treat everybody 100%. Sometimes 2 or 3 times they were lying, you know, on the charts. You know, all these studies are completely false. So they get 2 or 3 antibiotics taken. And then we have been fighting for, and be quite efficient for 10 years in avoiding to get the new molecule coming in the hospital for 3 years. Because all the money is coming for the 3 first years. So if you can avoid them to come in, it's not going to kill anybody, but it's going to save, you know, the big pressure of the money. This was the first thing. Now what I'm doing, my next step is I don't want to participate to any study, microbiology, that is a non-inferiority protocol. I think that non-inferiority protocol is a shame, so I don't want to participate to this. So we will not have any phase 3. Even if they want to, they can't, because I will never give my name. Okay. So this is one of the things that you can fight against the big pressure of the money on the new compound. And of course, the other thing is that, of course, antibiotic is a big thing, but it's not the only one. And if you look in your study, if you need on control, I can make a suggestion on your very first. If you need control, what you need to see is, because of course, when you look at people with these infections, in fact, they have been there since 3 months, and their life expectancy without any infection is much lower than those that are here. For example, in critical care unit, after 1 week hospitalization, your life expectancy is diminished by 30%. So 30% of the people who are more than 1 week will die, whatever. So if you want to control, you need to control that with non-infected patients that have exactly the same stay in the hospital, and see how long, you know, this is the right control. You cannot compare, you know, non-resistant and susceptible. You should compare, you know, the same length of the same kind of patient with and without an infection at time point, and see what happens. Okay?
That's a discussion.
And I think there is no difference. I think that they are not killed by or the people don't know, you know, what to use to antibiotic, because in our case, as far as I remember, since 20 years we have seen 2 cases where we don't get any antibiotics to prescribe. Okay, 1 case died with a Enterobacter infection. We have made 3 papers out of it, just because it was so rare. And we get the second one 5 years ago, or 5 years ago, it was Acinetobacter baumannii was resistant to everything, and the patient cured without any antibiotic. Get septicemia, get out of the critical unit infection. So this is very, very rare. And even these very, very resistant bugs, not Klebsiella, but the very, very resistant bugs are not necessarily the more rapid killer. So this study has to be very, the conclusion on this study, I'm fighting in my country with, the study saying, well, those with a resistant bug die more than, but they're different. They're different. They're not the same. They're not the same patient, so you cannot compare just one to the other.
A few comments. I think fosfomycin minocycline we don't have in Israel. I think we should have. I'll put my efforts on this with the pharmacy. There's no problem. We can bring it to Israel. I think it's very important. The pharmaceutical company is a terrible mistake. Yeah, that's true. I see a curve of echinocandin used in my ICU after the company has come to visit the head of the ICU unit, and that should not be allowed. That's third world, and that this belongs 50 years back. I think we need to move forward, and I move this forward when I return to my hospital, something that I've started and has not continued. The discussion of the appropriate control to examine the impact of resistance, it's a discussion in the medical literature. It's a big issue. I completely agree that the resistant and the susceptible are different populations, and like I said, there is nothing that can control for the differences. The patient with lymphoma that I just saw you is going to die because of lymphoma. I know that because she's recurred and she was transplanted because of recurrence. But comparing to those without infection, on the other hand, is problematic. I think the thing that helps in this study is that each and every patient undergoing bone marrow transplantation has bacteria at some point. So there are no non-infected patients in hematology. So that's pretty simple. But it's a discussion.
No, I think if you compare the fatality rate, we've done that for bacteremia, for example. We look at the fatality rate if at the same time you get blood culture with a bug and blood culture without bug, and see the outcome, different outcome. And if you compare that in different populations, in populations that is here since 1 month and a population which is here since 3 months, and look at the increase of fatality rate in those with susceptible bugs compared to resistant bugs, and see the increase of fatality, compare one to the other. You make an opinion. You can make an opinion on is it killing more or not. So the appropriate control, from my point of view, is blood culture same time, but no bacteria within. And this is the proper control, I think.
Just in the study, you have to take care of the immortal time bias, the fact that those infected cannot die until they have an infection by definition, because you took them when they're infected. So it's not
take the blood culture.
I'm sure
take the blood culture sample at the same time and see.
Yeah, but the patient is alive when you took the blood culture. So you define a certain period where he has to be alive until the blood culture was taken. But I'm sure you took care of that. I hear.
Des questions?
We recently compared between CRE colonized patients in our ICU versus matched controls that never had colonization of CRE to see the impact of the colonization on infections and mortality. And there was a difference as far as we could control for the huge differences between colonized and non-colonized. I'm pretty sure that there is an impact to resistance.
Well, and there is, I don't know, you get this in Israel. I'm trying to do this in France, but nobody cares. If you go on the source that you have in France, I realized that this work of the guy from Besançon, that they use epuration waste from the hospital. They use that, they sell, there's plenty of multi-resistant bug from the hospital. They sell that to the peasant to put that on the garden just to grow this thing. So there is, did you know that?
we've published one in CMI, and there is one that has been published in CID in Besançon, and then this is unbelievable. They take all the waste from the hospital, they concentrate that, and they use that, they sell that in the agriculture. And this may explain, you got this outbreak, in pigs or chicken, just because it go from here. So there is one.
That's one more circle.
Oh yeah. This is what I'm saying. There is one more. So from the hospital, you go to the antibiotic use in animals, just because it is the same. So and they sell it. And I asked my Ministry of Health. I said, we don't care. There is not so much with it. You're asking where it comes from, because of course in the community there is no. In France you cannot prescribe imipenem. So all imipenem resistance come from the hospital, or natural resistance. So where does this come from? Where does the material-resistant Staph aureus come from? It comes probably from the hospital, because we inoculate the agriculture with it. You didn't use that? I don't know how it's working in Israel. And it's make a lot of money out of it. They make a lot of money out of it. Good, thank you very much.